to Paul and colleagues for the population of the report. It's comprehensive. It's all written in there. There's nothing in particular I want to pull out other than in 30 seconds. And the planning framework is substantial, significant. I set out the planning guidance and helpful summary from NHS providers to non-exec colleagues, and we will do that justice on more than one occasion over Q3 and Q4. Particularly, I wanted to say in that space. Otherwise, we will come in the second part of the board, and I'll talk in the executive update around next steps for 1LSC. So nothing else I wanted to pull out on that. Any questions?
Any questions on the provider coverage update? Tony?
Yeah, thanks, Scott. Really good report. Just on not meeting criteria to resign, I noticed that there were some comments about that from Marble Trust. Is there a scorecard across the system? Do we see that? Because it'd be quite helpful to see where we sit and what the relative issues are.
There is. We can circulate that in a very short shrift. We're at around 25%. The other providers are at around 15, 12, 10.
Right.
But we can certainly circulate that.
Yeah, that'd be helpful.
Yeah, that is an action.
Smashing. Any other questions? Sarah?
Thank you. So I note that the provider collaborative board have agreed to move to the lead provider model for 1LSC. And I think my understanding is that there's then a review around service level agreements that relates to that. What's the process for that happening? Just thinking about the number of points that have come up this morning already that relate to one 1LSC implementation. Just to have some assurance around colleagues' involvement in that process.
Sure. So the joint committee obviously agreed that, and it came to the board for information and discussion. And it outlined there would be in Q3 the governance arrangements would emerge. It'd be fair to say they need to emerge more rapidly, and that's a live conversation with the chief executives. So there's a team working on it now. I think particularly with Ali, Helen, and Dee. In their various offices will get the opportunity to contribute to that. We do have a date where there'll be a perfect suite of documents on the shelf. I don't yet, but it's a very live conversation.
Thank you.
Any?
Not assured yet. In conclusion.
I think in terms of assurance, so as at today, of course, the strategic collaboration agreement is still the primary vehicle. The move to lead provider and therefore having the SLAs and the workboard governance, I'll be honest, that is less clear today than any of us would want it to be. And so there's work for us to do as a system.
So just to provide a little bit more of a kind of positioning on some of this, I'm working with the head of risk in terms of actually logging something on the risk register at this time, given that we don't have the full governance arrangements in place and we are in a phase of transition, but the actual change has enacted. So I'm working with the head of risk to make sure that that's profiled on the risk register this week.
Thank you.
Thank you. Nicola.
Just a couple of follow-ups, if I may, Chair, on the questions raised by my colleagues. So in relation to the risk, would it be possible for me to have sight of that? Because I'd like to raise that with the joint chairs of audit, because we're looking at how we're all doing the same thing effectively. And then secondly, in relation to the benefits review, would there be the opportunity for us to be able to have sight of those so that we can also triangulate those against our own local targets and understand the implications of funds at system level on the collaborative level?
Sorry, Nicola, do you want to unpack that a bit for me?
Right. So you talked about the fact that you went through the portfolio benefits and they were assessed. Is there an opportunity for the individual trust to have sight of those as well, so that we can understand what the implications might be between performance at a system level and performance as an individual trust?
Yeah. So right now, I don't think there is a plan on the shelf for that, but you're right, there should be. So yes, take that as an action.
Thank you.
Great. Helen?
We've also spoken to our external auditors, as have the other organisations, about the implications from an accounting perspective. So they're all fully briefed on the situation and obviously supporting us to ensure that we're doing the right thing in terms of accounting.
Could we pick up in our next pre-meet with the auditors for the next audit? Thank you.
Great, thank you. If there are no further comments on that, we'll turn to item 79I, the research and development update from Chief Medical Officer Helen.
Chair. So what we want to do within the paper is to give an idea of where we're at, where we want to get to in terms of thinking a bit further forward around strategy. And we know that obviously a research active organisation has improved quality of care. So it's a really important thing. So I'll take the report obviously as read. I just want to highlight a couple of areas just around that sort of strategy and obviously our aim for refreshing, but also around our fact that we want obviously more patients to get the opportunity to be part of research if they choose to do so, and more about people involved in research. You can see some improvement there on page 311 around recruitment in terms of ahead of the target, and then also later in the paper some opportunities around how income could be improved by obviously that increased recruitment and a real focus on being research active. We are already, but there's more that we can do, and that's what we wanted to do in terms of showing that ambition within the paper. In the thing of time, I'm happy to take any questions.
Thank you. Any questions for Helen? Karen.
Oh, thank you, Helen. It's fantastic to see this being refreshed. And this is just a forward-looking question. So I can see in the paper there's specific reference to clinical research. I just wonder whether we have an ambition as a trust to widen our research lens. I'm thinking of all of the learning and research opportunities that would sit around workforce change, managing that well, the transformation agenda. Are we going to take steps towards a wider angle lens, including but beyond the clinical research agenda?
Yeah, no, that's a really good point, and I'm catching up with some of the research team next week, so I'll certainly bring that in terms of making sure that we focus on that. You're right, we've been focusing very much on clinical and obviously giving our people and our patients more opportunity, but I'll certainly bring that into that discussion next week. Thank you.
Super, thanks, Helen, and happy to support that in any way if that's appropriate and helpful.
Thank you.
Thanks, Karen. Sarah.
Thank you. Likewise, it's a really good paper, I think, as an update on direction of travel with research and development. I feel much more assured actually by this than perhaps previous updates we've had on R&D, so really helpful. I think building on Karen's point actually, obviously the trust has MOUs with two universities, Lancaster University and University of Cumbria, which bring a variety of research disciplines and expertise, as Karen notes, probably not about the universities, but I can note on behalf of both those universities across a range of disciplines that go beyond clinical research. So I think through those MOUs, there's a real opportunity to consider what that opportunity, but what the opportunity is to build on. I know there are some examples already of collaboration around specific research projects, because I think it extends to also how we use data, how we think about our estates, and even designing hospitals spaces for the future as well. So there's a lot in there, I think, that can be drawn upon.
Nicola.
Yes, thank you. Excellent report, really useful to see what's happening in this area, and particularly, as you imagine, really good to see how we want to utilise data to support research, and that would extend to all clinical areas. I just was questioning, can we be assured or reassured, perhaps more appropriately in this context, as to that we have the infrastructure readiness to be able to facilitate and access that anonymised data in an effective way, and to also be able to pick up the relevant data sharing agreements and also the charges that we may wish to impose.
So there is significant work around the secure data platform in terms of across Lancashire and South Cumbria. We're involved in that, and so there should be no reason why we shouldn't be able to provide all of that appropriately pseudonymised data and fully anonymised data for purposes of sharing with research partners.
We'll be able to use one optimised architecture for this rather than a separate. Fantastic, thank you.
Thank you very much. Any other questions on this item? If not, we'll turn to the second part, which is the 10-point plan to improve resident doctors' working lives. Oh,
Thank you, Chair. This has come from NHS England, one to meet the 10-point plan to doctors' working lives. I'll take the report as read. Within this, we wanted to show the range of things that were covered within the 10-point plan. There's a number of things that were awaited in terms of things like specification around rules, things like that from NHS England, which have now happened. So a number of things have actually moved on since this paper. You can see, just highlight a couple of things on the first page of the report around the 10 objectives and what's being worked through. And on the second page, just where we're at. But as I said, just to say we have already implemented some of those that are in amber that we've just got through in terms of the specification. So we're working through this and we are where we wanted to be in terms of this. You can see that a number of them are already green. Those that are amber we've moved on with. We are required to report to the board on this in terms of ongoing, and I know that's been discussed in terms of that schedule to be able to just to say that I'm the senior sort of SRO from the point of view of one of the requirements in terms of the 10-point plan. Also have a representative as part of the resident doctors committee. So working to plan a number of things that we're just working on, and we'll be reporting this through the CBI People Committee through to the board.
thank you, Helen, for all your work in this area. Any questions? There are no questions. We're being asked as a board to note the report. We're happy to note that. Yeah, great. We'll move on to item 80 then, the board assurance framework, and I'll ask the company secretary to present.
Thank you, Chair. Enclosed in your agenda pack is a covering report and the board reporting tool. I'll take both as read, but just a couple of points that I just want to escalate and then maybe a reflection, Chair, about looking ahead. So firstly, just to confirm that the board assurance framework wasn't considered by the People Committee on Monday, but in a conversation with Karen, we're going to reschedule that to make sure that gets considered at the earliest opportunity. I won't go into detail in the report. You'll see that many of the themes, comments and narrative in there have actually featured in various discussions today, the 3A reports and the RPR amongst others. When the question was put to the various committees about whether or not there was sufficient progress for change to be scores to be de-escalated, there wasn't, and I think that reflects the challenging operating environment that we're in. What I wanted to do, though, was really just to kind of expand on the final paragraph of the covering report at page 335, which is this idea of looking ahead. So as I was drafting this report, I'm just reflecting on the fact that there's been 2 declarations of open for. There is some industrial action taking place in November. Obviously, our usual response will be initiated to that. But the reflection is, what about our risk appetite? Earlier this year, there were some red lines agreed by the board, if you like, and those were things that we would not accept. And there were some areas that we thought we might tolerate, including potential temporary changes in colleague satisfaction. Just thinking about the various issues that have been raised today, the challenging operating environment, the impact of the programmes of change that we're still working through, Ali's comments around kind of ongoing referrals to occupational health. I think there's some work to be done through the executive team and through our assurance committees, just to kind of reflect on those stakes in the ground we're playing. Are we butting up against them? And do we just need to be mindful that we don't cross any of those stakes in the ground that you discussed and agreed as part of your story? So it's not for a debate today, but I think there is something there that as we go through the next phase of business through the executive team and with our non-executive director colleagues, that we just reflect on those to make sure that we don't find ourselves stepping too far away from those kind of objectives and commitments that you made. With that, if there are any questions, Chair, I'd be happy to take them, but I would ask the committee to the board to approve the board assurance framework and agree that we'll just be mindful of the stakes in the ground that we laid earlier in the year. Thank you.
Thank you, Paul. Any questions, Sarah?
So it's not a question actually, and I know it wasn't to open up debate for, so I'm hopefully not going to take us down that route. But actually just thinking about, is there a process already for that? So do we as a board do a sort of half-year review of our strategy, etc., which would then open up the opportunity to think about the risk appetite and where we are against that in the context of that discussion? And that might be a useful way for us to do it. Yeah. Would that be at the next meeting?
We'll take that offline. So I think there is a process where we do those quarterly and half-year
Yeah.
reviews, and I think that would be the most appropriate place to take that for some additional work.
Great, thank you.
Thanks, Tony.
It's just to say I support that. I think it's a unitary board, it's a collective conversation, rather take it to the side of committees.
Thank you. If there are no further comments, we're happy to approve the recommendation of the committees. Yes.
Yeah.
Great. We'll move on to item 81, an amendment to the Trust Constitution, a review of appointed governors. Paul.
Thank you, Chair. Responsibility for changes to the Constitution are vested in the Board of Directors. You'll see in your pack a covering report following the discussion that's taken place through our Council of Governors to review the appointed governors that are appointed to the Council. The report is self-explanatory. You're asked to approve the changes recommended in the Constitution. Thank you.
Susie, is there anything you want to add on this?
It was work that needed doing, let's put it that way, because we did have quite a few gaps that we've now got quite a few people, which is good.
Excellent. Any questions?
Yeah, totally support.
If not, everyone's happy. So we're happy with the recommendation to approve the recommended amendments to the Trust Constitution. Yeah. Great. We'll move on to item 82, NHS Oversight Framework, Provider Capability Assessment. And can I ask the Interim Director of Governance and Assurance, Sarah Hawkswell, to take us through it?
Yes, Chair. So I will start by saying this is the work being led by Tamsin and Paul around this. And as you're all aware from a previous board session, we are in parallel with our NHS Oversight Framework required to do a capability assessment. And the basis of that is, does the board know its business, and does the board know what's going on in the organisation? And there are 6 key areas of focus which link into the Insight for board, and we're required to assess ourselves, give ourselves an overall grading, and they are against those 6 bullet points on page 1 of the report. And so in the private board, we will be looking to say whether we are confirmed, partly confirmed, or not confirmed against those 6 areas. This paper sets out evidence we've gathered by meeting with the executive directors and the non-executive directors, which relate to those key 6 areas within the organisation. I think we have been, as we tend to be, very open and honest with some areas in particular, and probably lean towards the self-critical as an organisation when I've looked at other organisations and how they've done this. So in terms of, if I look at around strategy, leadership and planning, we've reflected that our digital strategy doesn't align to the 10-year plan. I think it would probably be unreasonable for us to have received the 10-year plan and come up with a 5-year digital strategy in terms of doing that. So I would suggest that's further work rather than something that's missing from within the organisation. In terms of our enforcement actions, Helen may wish to come in here. It's around, are we meeting the specific enforcement actions, which is a quarter-on-quarter improvement, which we are doing. But obviously we've heard around the financial position of the organisation, which is something slightly different. In terms of skills, capacity and experience to lead the organisation, when we discussed this yesterday, I think Lynn brought up a really strong point here, which is, and actually it reflects something Nicola said in the conversation offline, which was the fact we have people internally in the organisation who have been able to step up into those roles and who have the institutional memory, means we do have the capacity and skills within the organisation to do this because we've developed them and they know the organisation. And then the Trust is working effectively and collaborative with the system partners and NHS collaborative for the overall good of the system and population served. I think that's an area we probably want to pick up as a conversation in private board, particularly with some of the one LSC issues we've had and conversations we've had today. Quality of care, and this largely relates to this is around the data and do we have systems and processes in place. It is separate than are we performing and delivering, which is part of the NHS oversight framework. I think everyone knows from the work we did in RSP, we have robust systems and processes in place, but things continue to go wrong, but we are meeting our regulatory requirements in terms of that. Systems and processes that are in place to monitor patient experience, and we've talked about FTT, how we plan to strengthen that, but we do have systems and processes in place. People and culture, I think it's important to tie this back to those conversations we had at the start of the year about what we may have to accept and what we wouldn't accept in relation to our strategic priorities. Because I think this is something where if you talk to our staff, they may give a slightly different thing than we would perhaps feel. So again, I think it's the conversation in private board that we wish to have. Staff with the relevant skills, etc. Capacity to undertake their role. And I know, Karen, there's lots of work going on in the team around what we do and how we do it. And staff can express concerns in an open and constructive. And we've obviously talked about gaps in freedom to speak up, which we are mitigating. So I think largely we have systems and processes in place in order to deliver these things. And it's just a reminder to people that when we look at the actual scoring we're going to give this afternoon, it's about the systems and processes and not necessarily about our performance against those areas, because that's measured by the NHS oversight framework. And I think this document reflects all the conversations that have been had with people. I don't know if anybody else on the board wishes to come in and highlight anything else that was said in a conversation that you didn't feel was captured in the document.
So, Sarah?
No, but I think just to support, we had a discussion around quality and safety. I had that with Paul and Sarah, and things we discussed I see reflected in the report. So I think it's important to acknowledge that as well as say if there are any gaps. So I feel that those points have been taken into account. Thank you, including actually some of the points I made about the fact around the board transition at the moment, but actually a lot of those people know the organisation, so it's still quite stable, even though we've got changes in roles. Got a number of people who know the organisation.
Tony?
Yeah, I mean, I actually, in a bizarre way, welcome this in a way. It's quite a helpful tool to have. It's context really in terms of frequency. So what's the frequency of it?
Annual.
And then have we got the process and methodology to sustain that rather than keep reinventing the wheel? And then the third bit is the read across down things like well-led. Because in a sense, you can feel this kind of pulling together, but it's nice to do these things joined up at once rather than kind of multiple times in a scattergun approach.
So my view would be now that we know this is, now that we have this template that we know we're going to be required to complete, we'd almost build it into our annual planning and oversight framework. Because we know as part of that planning, we're going to be required to do an annual self-assessment around our capability as a board. So we'd look to do that in I'm going to say November, December, I can't remember which quarter that is, Q3 of the year, so that it's ready for the January.
So just again, in terms of methodology, so in terms of, so on the basis of the conversation we had about the BAP, which in a sense is a kind of mirror image of it in a sense from a different perspective, it's using those opportunities throughout the year to kind of keep the thing continually populated so that when someone says, can you do it? We've almost got it in real terms rather than just let's do it now.
So there's a supported by our interim chief exec, you'll be aware that I've been agitating for a strategic risk group, which will be chaired by the chief exec, which we are going to implement. That the output of that strategic risk group will identify the gaps and issues within this area, because as you say, it largely reflects partners exactly as we've identified in the back. But that meeting will have built into it. Is there anything we need to add to that document? Almost as a real-time update to it.
Sorry, Chair, just one final thing, because it's quite key this. And then presumably CQC well led will principally have this as a kind of narrative or the updated versions.
Yeah.
To kind of inform their approach.
So CQC, so bizarrely at the Enterprise Board, I'm joining a national call around the updated approach to well led. I'm so important. Taking of but it does start to mirror this. So it does feel like they're joining the dots.
Thank you, Chair.
Nicola.
Yeah, I'm not, I don't want to get into conversations I think we might get into this afternoon, but I think what it is indicating to me, and I'm just seeking your view on this, is that with this framework, it's very much about us demonstrating that we know ourselves and that it will be triangulated with any information other parties already know about us. And I think it's sort of a reassurance that the executive who have led the provision of this evidence, feel that we have truly reflected that there isn't anything that we have not perhaps been as open or transparent in here that we know that we have been examining. Because my sense is we have, but I just want to get reassurance because I don't cover absolutely every topic here, particularly around people and particularly around what.
So I've gone through this and I've also compared it to multiple other documents in other organisations. And it is, I know you've had the experience in yours, but it's a lot longer than other places. Some places have just put complete for everything and put 6 or 7 bullet points. I think we have been very explicit in terms of the evidence we have used and how we've made them. I'm not aware of anything or anything that's been externalised that we've not reflected in this report.
I wouldn't feel comfortable commenting on how well or not another board has done this that I'm on, but what I would say is that I am really impressed by how you have presented the supporting information. You've not just said this is a document, it'll be in there somewhere. You've given the context for it, and I think that's really important because I think that's what ensures that we have demonstrated real self-awareness as an organisation.
Thank you. Karen.
Oh, thank you. And thank you, Sarah, for the conversation about this, the ones you referred to earlier with execs and non-execs, really helpful to really understand the particular lens that this is casting. And this may be something that we explore further this afternoon. It just, I think it's important to make the connections between the capability that's reflected here that arguably reflects process and actually how that translates into the impact that we're looking for. So I think for me, just in terms of joining up the thinking, it will be really helpful, for example, to see how some of the Chloes that we have here at board level actually track through our divisions and into the action, which is where the difference is actually made. So I'm sure that's something that you're kind of thinking about. I know it's not what this tool in particular is designed to do, but I think organisationally for us, and speaking personally, definitely for me, being able to make those connections will be a really helpful future development.
Thank you. Thank you, Karen. Any further questions or comments? If not, thank you all. We note that and we'll continue the discussion later on in the second part of the board meeting. If we turn to item 83 then, Health and Safety Committee Annual Report. Sarah.
The consent item, Chair, so I won't discuss it. Okay. Any questions?
Happy just to note any questions? No. Item 84, elective and urgent and emergency care delivery template. Dee.
Thank you, Chair. Thank you. So again, I'll take this item as read and the contents of this item is in the narrative in the agenda. There's a copy of the letter enclosed that was sent back from current interim chief executive, which identifies the response to the letter that we've given. What it does say, which is really quite clear, is some of the context in terms of our elective recovery targets and why we have given those targets that we have given because we have the funding gap that I referred to in the IPR earlier. And also the removal of individual patient transfers across the ICB and the impact of that financially and on our patient waiting list. The other, in terms of the UEC recovery plan, the trajectories were already set. We'd set them ourselves. So what we had to do was stipulate against those trajectories, which are a downward trajectory because it's winter. So instead of the performance going up, we're going downwards, taking winter into context. But that had already been set. That was not in question. It was our assurance in terms of what we were going to do to ensure that we achieved those trajectories that we had set ourselves. These have been signed off because of the timescales that were involved, because it was a very late task with a very short window of about 5 days by our chair, as well as our then CEO, our interim CEO, and I'm in as chair of finance and performance as well. So it's to bring this here for visibility and for any questions, please.
Thank you, Dean. Any questions? Sarah?
Thank you. So I know it's a consent item, so we're not really.
So just to be clear, for the board, it's not for approval
No,
because it's already been approved.
No, and I do understand that. It's actually a clarification question though in terms of what's in here. You reference in the letter, I think it's referenced a couple of times, that there's an impact from the removal of individual patient transfers across the ICB, and that's had a material impact on the waiting list. What does that mean in terms of what is the removal of individual patient transfers?
I think it been my letter. But it's important. It is important, and it's a salutary lesson for next year's planning. So, as we've told the board many times, before the start of this financial year and during, stand still at 70.1% RTT, and spend billions of pounds of less resources was going to be challenging in and of itself. And we're on project. After the planning submission, two things happened. The annual growth was not funded, which is anywhere between 1.5% and 3%, and the individual patient transfers. So effectively, there is a block where we take in referrals, and in selected cohorts of patients, they are outsourced to the private sector. And the payment vehicle within IPT. It was the payment vehicle for transferring activity to the private sector. And last year, of our 70.1% performance, 2.4% of that was done by that vehicle and paid for. So that didn't happen, likely won't happen going forward. What that means is, if we do achieve a goal of 70.1%, had we had growth funded and that same level of IPT, it would actually be a 73 point something. So it's material to our performance. It's an unfortunate consequence of the planning timetable. So, we submit a plan, it's locked and it's signed on, and then so and this year, Carla, who's very expert in this space, will be all over that in terms of making sure that those line up. They may still not line up. There may still be decisions around pass-through money from the ICB that happen after the planning event that's going to be.
Thank you. And so removal of it means that that's no longer funded by the ICB when we outsource that particular code.
In which case, we no longer outsource patients, yes, because obviously we're not resourced for that, yeah, and it's the RTP challenge.
Thank you. That's really helpful. Thank you.
Any other points of clarification? No. If not, the attendance monitor and the schedule of business have been circulated for everyone to note. I have not been notified of any additional urgent business. The time, date and venue of the next public board meeting will be Wednesday, the 7th of January at 9 AM in the boardroom here at Westmoreland General Hospital. Part 2 of the board will recommence at 1 o'clock this afternoon, and I will therefore resolve that representatives of the press and members of the public will be excluded from the remainder of the meeting, having regard to the confidential nature of the business to be transacted. Can I thank everyone for attending this morning session and remind you that flu jabs are available at 1 o'clock.
Thank you.
Thank you.